An exciting new development in the management of heart failure involves the use of SGLT-2 inhibitors, but is there any evidence they help, and if they are of benefit, who should we be offering them to? SGLT-2 inhibitors, such as dapagliflozin and empagliflozin, are drugs used in the treatment of diabetes and exert their action on glucose transporters located in nephrons to prevent the reabsorption of glucose. Through this mechanism, they lower serum glucose and are also able to exert a diuretic effect. Once this drug was marketed, cardiovascular safety was assessed over long-term studies, and a study published in the New England Journal in 2015 in fact found that patients with diabetes on this drug were significantly less likely to die from cardiovascular disease and be hospitalized for heart failure. This prompted speculation that the medication could be beneficial for patients with heart failure without diabetes. A study led by John McMurray in 2019 was performed to answer this very question. Patients with heart failure and an ejection fraction of 40% or lower, with or without diabetes, were randomized to receive either a placebo drug or dapagliflozin once a day. Over a period of 18 months, the risk of worsening heart failure or death from a cardiovascular cause was significantly lower in the group given dapagliflozin. Following this, a separate randomized placebo-controlled trial was performed by Stefan Anker and others in 2021, which looked at empagliflozin in those with heart failure and a preserved ejection fraction, again with or without coexisting diabetes. This study found that empagliflozin reduced the combined risk of death from a cardiovascular cause or hospitalization from heart failure. Multiple other studies since have demonstrated a largely beneficial effect of SGLT-2 inhibitors in heart failure. The mechanism it produces its effect is unclear, although it is postulated that its glucose-lowering effect likely has a beneficial role in preventing further inflammation and fibrosis of the heart. Furthermore, the drug's ability to cause diuresis likely reduces preload of the heart as well. Given that SGLT-2 inhibitors are generally helpful in those with congestive cardiac failure, regardless of the ejection fraction, a good question to ask is which patients are likely not to benefit from the drug. This class of drug can precipitate ketoacidosis even in the presence of euglycemia, and therefore its use should be avoided in type 1 diabetics and in those with a history of diabetic ketoacidosis. Furthermore, given its diuretic effect, it should be avoided in states of volume depletion and hypotension. Finally, caution should be exercised in its use in severe hepatic and renal impairment.